Now we have the last session for the evening, and for this I would like to invite Dr. Ritu Huda, Dr. Akta Bajaj, Dr. Saguna Shukla, and Dr. Smriti Attam.
Hello and good afternoon, everybody. It's rather good evening. And I think this is the last session. And in this, we are going to be discussing about menopausal hormone therapy. Dr. Rajneesh Mittal is going to give us insight. As the reproductive age starts declining, we are at the end of the session of endocrine. So Dr. Rajneesh is working at Mittal Super Speciality Hospital at Yamuna Nagar. And he's a senior consultant endocrinologist. I think a lot of gynecologists who will be benefiting, because day-to-day practice we are seeing a lot of menopausal women having real problems and how we can tackle them.
A very warm good evening to all of you. Thank you, SPEEDCON, for giving me a chance to deliver a lecture on this topic. I think this topic is quite important. And in fact, even I had a lot of insight while reading and preparing for these slides while I was going through menopausal hormonal therapy. So my topic, the outline is small introduction and history about MHD, then WHI trial, then the choice of estrogen that we can prefer in using MHD, choice of progesterone with associated breast cancer risk, VTE and CVD risk, and how do we approach the patient, then other hormonal options and summary. So how exactly we define menopause? I'm sure that all of us are quite well versed. So the basic thing is menopause is the permanent cessation of menstrual cycles, whereas the perimenopausal period is from the first features of approaching menopause until up to 1 year after final menstrual period. We know that initially early when patient develops menopause, she will get vasomotor symptoms predominantly in terms of hot flushes, sweating, insomnia, menstrual irregularity and psychological symptoms, followed by predominantly genitourinary symptoms like vaginal atrophy, dyspareunia, skin atrophy, urge stress incontinence, and of course later on, long-standing, she might get some bone-related issues like osteoporosis and atherosclerosis. And of course, throughout the lifetime, she will have reduced quality of life. When we talk of menopause and we go back almost 2000 years, menopause as a life event has been recognized for past 2000 years, but treatment of these women has generally been poor. Not until the 20th century was menopause defined as a deficiency disease, and menopause was attributed to estrogen deficiency. Thereafter, treatment with estrogen became not only legitimate, but rather an obligation. So when we look at the average age of Indian women vis-a-vis and compare with the Western population, the average age at what Indian women get menopause is around 46.2 years, whereas the Western population is around 51 years. So our Indian women get menopause quite early as compared to the Western counterpart. And of course, they are quite symptomatic. They might feel 33% will feel social life is affected, 51% feel sexual activity is affected, 81% will have low BMD, 45% will struggle at work, and they are 2 times prone for the risk of CHD. Just a small and quick history. Basically, in 1890s, the pulverized cow ovaries were taken. That is, it was taken from the dead cows. The ovaries were taken, and actually from there they took the estrogen extract and they tried to treat the climacteric symptoms. Then in 1940s, it was early 1940s when conjugated equine estrogen was procured from the pregnant mares, and from 1940 till 1990s this was used, and HRT actually gained the prescription, and even by the end of 1990s or early 1990s, 30% of female physicians also started using HRT to prevent the disease. Not until the publication of WHI that happened in 2002, which said that actually the HRT might be associated with some risk factors. You can see that in 2040, there were around 20 million prescriptions of HRT, which soared to almost 90 million by 2000. but immediately crashed after the publication of WHI, and prescriptions were almost around 20 to 30 million by the 2003. So what exactly was a WHI trial? It is very important for us to understand, because WHI trial was a one trial which actually crashed the use of MHD. So it was the largest evidence for the use of MHD. They had two arms. One arm, practically one patient, they gave CEE with medroxyprogesterone acetate. Another arm, they gave CEE, and in parallelly, they had placebo arms as well. This was planned to investigate the effects of HRT on older postmenopausal women. So they wanted to see that if we give HRT to the older women, do we really get some beneficial effects in terms of CHD or no? The average age that was selected in this population was 63 years. That's very important, because in WHI trial, they took little bit elderly population or elderly ladies, and they had put them or recruited them on either CE or a combination of CE and medroxyprogesterone acetate. You can see that around 30%, that is 10%, were between 50 to 54, and 20 were between 50 to 59. So altogether, only 30% of population had age less than 59, whereas almost 70% population had higher age. And the primary outcome was cardiovascular health, secondary outcome was bone health and cardiovascular health. Then, of course, why this WHI study came, mainly it was based on the 2-decade studies, observation studies, which showed that when you give HRT to the woman, they will have some reduction in coronary artery disease and mortality. Based on those observations, they wanted to have a prospective randomized trials. Another important point was that they never wanted to treat the vasomotor symptoms of menopause in this WHI trial. Their main focus was on the prevention of cardiovascular disease, not to show the beneficial effects of MHD on the vasomotor symptoms. And then in 2002, practically before the data could be actually analyzed according to the age-wise and the preparation and the arms, practically the data got leaked with the print media, and the science was vetted by the media, and it actually, media literally made a scapegoat of science, and they said that this HRT is causing a lot of breast cancer related issues. It was spread like a fire. It went to the patients, to the women who were actually using HRT, and the trial had to stop immediately. So there were perceptions that even though the HRT had a beneficial effects, but the risks outweighed the beneficial effects in terms of increased cardiovascular risk, risk of thromboembolic disease, risk of breast cancer, and risk of death. So it was then when it was perceived that whatever MHD or whatever the preparation of MHD you use is a class effect. So if you change the estrogen preparation, if you change the progesterone preparation, still you are going to have the ill effects of MHD. If we really critically analyze WHI, we have to understand that it was a very high risk population that was chosen in WHI trial. The ladies were more obese. The BMI of 69.5% population was more than 25. Elderly population, they had family history of breast cancer, 16%, smokers, hypertensive, and CVD. So it was a high risk population. Ultimately, even before they could be put on HRT, they were already prone to develop coronary heart disease. It was then in 15 years post WHI in 2018 when Professor Manson, who was the chief investigator of WHI study, he said that the big concern in clinical practice is not the overuse of hormone therapy for prevention of chronic conditions, it's the underutilization and undertreatment of women who have hot flushes, night sweats, disruptive sleep, and impaired quality of life, and are otherwise appropriate candidates for hormonal therapy who are not actually receiving treatment. So now today, can we really look at some data which helps us decide that we do have some preparations of available which are where we can accept that they can have a beneficial effect on the woman's health and not have the risks. So can we increase the acceptance and decrease the unwanted effects of MHD by appropriate selection of MHD? So if we look at the first component, that is the estrogen component of MHD, it was then after 2002 when there was serial number of studies that were related to vasomotor symptoms and use of estradiol. And so much publication, so much science came that a lot of societies from 2014 till date, like obstetric societies, menopausal societies, or Indian Menopause Society, endocrine societies, everybody started endorsing that we can use estrogen as a preparation to allay the symptoms of vasomotor symptoms. So we need to understand that what estrogens are more safer if we have to prescribe in terms of MHD. We need to understand we have two types of estrogens. One is oral and another is transdermal. In oral, we have three types of estrogen. One is 17-beta estradiol hemihydrate, another is estradiol valerate, and the third one is conjugated equine estrogen. We need to understand whenever we give oral estrogen, that drug has to undergo first pass metabolism through the liver. And they get metabolized to various estrons, estriols, or estradiols. It is an estradiol preparation which is quite safer, which does not increases the chances of VT because estron and estriol is prothrombotic. So these preparation, amongst these preparations, the 17-beta estradiol is chemically and biologically identical to endogenous human estradiol and is rapidly available after ingestion. So it causes actually minimum liver load when we are giving this formulation, thus actually not really increasing the chances of a prothrombotic episode, that is VTE. Then we compare oral estrogens with the transdermal estrogens. Of course, that goes beyond saying that there is a lot of evidence that says that the transdermal estrogens are much preferred as compared to the oral therapies of estrogen. There was a data from UK Journal of Practice Research database that was published in 2010, and there were a lot of studies that showed that there is an increased chances of stroke when we are using estrogen preparations. And this data showed that when we use transdermal estrogen in the form of low dose, it definitely does not increase the chances of stroke as compared to the high dose transdermal patch or low dose oral or high dose oral. Then progesterone, of course, all of you are well versed with this slide better than me, because this is one slide that you have been reading in obstetrics and is glaringly there in Datta. Important point in this slide I just want to highlight is on the dydrogesterone. That is that basically it is a stereoisomer of progesterone, so its structure is almost similar to progesterone. However, all those other progesterones are variously categorized according to the functions or the receptors that they stimulate. All those progesterones not only stimulate the progesterone receptors, but many of them concurrently stimulate either the glucocorticoid receptor or mineralocorticoid receptor or androgen receptors. So of course, once they have a different type of affinity for different type of receptors, so they won't only have the beneficial effects, but they might have some counterproductive effects by acting on the various other receptors. So when we compare these progesterones and we divide them into synthetic and natural progesterones, it is seen that the risk factors of VT, CVD, stroke and breast cancer are much less with natural progesterones as compared to the synthetic progesterones. So till 2002, medroxyprogesterone acetate was one of the progesterone that was actually in the limelight and mostly prescribed progesterone, and then it was really considered as hero. But after the trial, actually its use became zero because it is a potent agonist of progesterone, androgen and glucocorticoid receptor. It does not bind to estrogen receptors but acts as an anti-estrogen and also dilutes the beneficial effect of MHD on coronary outcomes. Then in 2016, the British Menopause Society really started looking at the various risk factors that are associated with breast cancer, like obesity, sedentary lifestyle, use of contraceptive pills, smoking and alcohol. And they compared those lifestyle modifiable risk factors with the use of MHD. And they saw that MHD per se does not increases that many fold chances of developing breast cancer as much as these routine problems are there. So the message from British Menopause Society was there that don't fear from the use of progestrogens for the fear of breast cancer. There are a lot many other things in women that should be looked into which causes more chances of developing breast cancer. Then it was a beautiful study from a Finnish cohort study published in 2009. This data basically wanted to look at the various preparations of progesterone. They added estradiol with various other progestrogens, and they saw that the preparation which used estradiol and dydrogesterone had almost, this was one, baseline risk was 1 without the use of MHD, and 13 times the risk increased when this combination was used in terms of breast cancer, but it was non-significant risk. But when they compared, looked at the other progesterones like MPA, NETA or the other progesterone, it was multifold times that increased the risk of breast cancer over and above the use of dydrogesterone. Similarly, a beautiful study, E3N study, again highlights the same thing. E3N study also showed that whether you use micronized progesterone or dydrogesterone, and when you compare these two progesterones with the use of other synthetic progesterones, the chances of developing breast cancer are much less. Then a lot of breast safety observation studies came into play, which really tried to look collectively on the progesterones and then differently on the progesterone. And then in 2019, we had a meta-analysis from Lancet, which was published in 2019. There they looked at all the previous studies, and they saw that predominantly used progesterone was levonorgestrel, norethistierone acetate, and medroxyprogesterone acetate. So most of the studies that were talking that this causes breast cancer, they saw that most of the times these three were the culprits that were used. Very rare, or there was very scarcity was there in the data who had used micronized progesterone or dydrogesterone to be told that this causes as breast cancer. Yes, there were studies. Yes, breast cancer was seen with these two as well, but the number of cases were quite less and minuscule and non-significant. Then a beautiful data that was published in 2020 in BMJ by Vinogradova group, and they actually again subsequently looked at the around 20,000 patients from UK who had breast cancer, and they divided them into various parts. They were on estrogen, they were on estrogen on progestrogens, they were on different preparations of progestrogens, and they again saw that there is no significant additional risk with estrogen and dydrogesterone compared with those patients who never had taken MHD. And as you can see, another extrapolation that can be done from this graph is that as and when you increase the tenure of use of progesterone, like this is from 1 year, 1 to 4 years, and more than 5 years, the chances of developing breast cancer increases. So that was another message from this trial, that you can use this progesterone quite safely for a shorter period of time, but if you try to use this beyond 5 years, the chances of developing breast cancer increases. It is likewise with the other progesterones as well. If you see levonorgestrel, norethistierone, or medroxyprogesterone, it goes like this. So the more it is towards on the right side from the forest plot graph, and the chances increases more. So this is a more chance, this is a lesser chance, and this is the least chance. Then again, they looked at the chances of developing breast cancer in those patients who had a recent use of MHD or the past use of MHD. Again, they saw whether the patient had earlier use of combination of estradiol, dydrogesterone, or the past use, they had lesser chances of developing breast cancer as compared to the other population. Then of course, it has been endorsed by many societies, and they say that the risk is lower with dydrogesterone and micronized progesterone than as compared to synthetic progesterone when it comes to breast risk. Then this was a review article in Climacteric February 2022, where the authors wanted to say that a clinician should never fear when he or she wants to use MHD on her patients if it is indicated, because the risk of breast cancer with estrogen progesterone therapy is quite low. Real risk is the lifestyle factors which could be modified. Use of micronized progesterone and dydrogesterone is a low risk for breast cancer. And interestingly, they also reviewed that breast cancer specific mortality is reduced in women who develop breast cancer on estrogen progesterone therapy. And of course, the benefits of MHD cannot be negated just thinking that it causes breast cancer risk. And now coming to the risk of VT, stroke, and CVD risk. So this was a Esther case control study which looked at consecutive to 71 venous thromboembolic cases, and they also saw that the patients who use micronized progesterone or pregnant derivatives like dydrogesterone, they had lesser chances of developing the venous thromboembolic episodes. This is the same thing, repetition again from the Vinogradova data. She has done a lot of work on this, and again endorsement was there based on these by the various societies. And they said that important thing is, definitely there are few oral preparations that do not cause breast cancer. However, if somebody is or venous thromboembolic episodes, I mean, but if somebody is prone and there is a definitive indication to use, then probably you can prefer transdermal preparations over oral preparations. Then is the timing hypothesis, which is quite important. Basically, the timing hypothesis states that you have to hit early, you have to start early. If you start early, the risk factors almost minuscule. The MHD started in perimenopausal or early postmenopausal, that is less than 10 years, is actually cardioprotective, and MHD begin late after the menopause, more than 10 years, increases the chances of CVD. So this was the meta-analysis which was published in 2006 that indicated a reduction in mortality in younger postmenopausal women who took hormonal therapy compared with women who never took any treatment. Similarly, Nurses Health Study, again, they did patients who took early therapy in menopause and then late, and they showed whether you are giving estrogen or you are giving estrogen and progesterone, they are having beneficial effects and influences the coronary risk. Then Cochrane meta-analysis from 2015 that also showed that if MHD started less than 10 years after menopause, it reduces the risk of all-cause mortality in CHD compared with placebo. Then how to approach a patient of menopause? Basically, a woman comes to you and suppose she is interested in MHD, then her age has to be less than 60 years and her menopause should be less than 10 years since menopause. If it is beyond, of course, we have to consider other options like SSRIs. And if she fulfills the criteria, then you have to rule out few things which I won't be going in detail. Once you rule out those things, evaluate her cardiovascular risk. If cardiovascular risk is low, evaluate her for the breast cancer risk. If the breast cancer risk is low, then the question that you need to know about that woman is whether she is having uterus or no. The reason being that we know that if we are giving continuous stimulation to the uterus by estrogens, it can develop endometrial CA. So we do need to add progesterogens so as to prevent endometrial CA. So if somebody is having uterus, then of course you need to give ENP. If somebody is not having a uterus, then you can probably give just estrogens. So this is a long list. That just tells us the contraindication for use of HRT. Then these are the dosages and type of estrogen and progestrogens that have been mentioned in Indian Menopausal Society for the use in HRT. The message in this slide I want to give is that you have to start the woman on lowest possible dose to allay the symptoms or vasomotor symptoms. And then gradually you have to build up the dose of lowest possible estrogens so that woman can have maximum beneficial effects. Similarly, it is for the progesterones, mainly the progesterones that can be used. If you want to use a combination of ENP, then of course you can use dydrogesterone and estradiol combination. If you want to use individually, then you can use micronized progesterone as well. You are better aware of this slide than me, that what are the types of HRT that we can use in a patient. Then just one message, when we compare oral estrogens with transdermal estrogens, only message is that one, that it is more effective, oral is more effective in reducing vasomotor symptoms and genitourinary symptoms. VTE risk is lesser with transdermal. And main thing is in India, the availability of transdermal preparation is a challenge and compliance is quite poor and it is quite expensive. So you have to actually weigh the patient that what risk factor your patient is having. More prone for VT, go for transdermal. If patient does not have any risk factors for a VT, you can prefer oral preparations. Other SERMs like Tibolon, and then we have bezidaxofene and ospemifene. Of course, these two SERMs are not available in our Indian market. And once you need to choose the ideal MHD, we need to have all these beneficial effects with MHD, but we are scared of this stroke, VT, C risk or CVD in more than 60 years. And we know that these side effects are quite rare with the use of estradiol, dydrogesterone or micronized progesterone. Then this is just to focus and comparison of various guidelines. Basically, I just wanted to focus on duration of use, that various guidelines just say that treat the vasomotor symptoms of the woman with minimum possible dosage for minimum time. And if somebody is going beyond 5 years of symptoms, we have to be quite judgmental. We have to see that whether she is developing further risk factors, whether we can continue giving her HRT or no. And in case she does not have any risk factors and we want to continue, then we have to give her lowest possible dosage to allay the symptoms. To summarize, the timing of menopause and its impact on symptom severity and quality of life varies from woman to woman. The MHD is beneficial in women who are less than 10 years post-menopause, less than 60 years of age, and have troublesome symptoms. Risk stratification and individualization is the key before we start any MHD, and reassessment is very important. Every yearly or annually we have to reassess once we put the patient on MHD. We have to start with a low dose and we have to keep it as a minimum duration required. oral estradiol and transdermal estrogen with dydrogesterone and micronized progesterone has a better safety profile. These are the various guidelines that have actually endorsed worldwide that for the vast majority of early postmenopausal women less than 60, it is a safe and quite effective option for the release of menopausal symptoms and prevention of osteoporosis. Thank you very much.
Thank you, Dr. Rajneesh, for the very elaborate discussion with literature. A few take-home messages for my gynae friends. 3 S's we should remember. 1, screening the patients before you give any HRT is very, very important, whether she requires it or not. Second, S is for symptoms. We always treat the menopausal symptoms, what the patient is facing. Like suppose hot flashes are there, the treatment is different. If she's risk for osteoporosis, risk for coronary, we have different reasons for treating the patients. Sometimes simple genitourinary symptoms are there where we just need transvaginal preparations, which I'm very commonly using. So they are very beneficial. The third S would be the smallest number. We should remember the smallest dose of estrogen is given wherever we think estrogen is the treatment for the HRT, which Dr. Rajneesh also pointed out many times. And regarding progesterone, the gynecologists only can tell that LNG, IUCDs we are using, Mirena we are using for many patients. We have early menopausal transition phase and a late menopausal transition phase. In the early menopausal years, like pre-menopause phase, we prefer giving only progesterone. We don't give estrogen. Whereas in the late menopausal, which is just 1 year prior to menopause, we add estrogen, progesterone in a cyclical way. And once menopause is set in, later we are giving the estrogen, progesterone, then we give a continuous estrogen, progesterone. Commonly, I'm using Premarin in a very low dose. Conjugate.
Probably now you can change your practice, ma'am.
So anyways, we are, this is the common thing I wanted for a lot of gynecologists sitting here. Thank you so much.
Thank you.
Yeah, thanks so much for the nice presentation, sir. So it's just that there is another key take-home message that we should not start and stop any hormonal therapy because that increases the risk of VTE several times. So when we start the HRT for any of our patients, we have to be sure that we taper it nicely and just don't suddenly stop it and restart it. So when we increase and when we restart any hormonal preparation, we are increasing the chances of variance thromboembolism.
So just a comment here,
the
message that you gave.
Yeah.
There is a lot of evidence that actually makes our decisions to stop HRT quite indecisive. There is evidence that says that you actually cannot stop HRT abruptly. And then there is a literature that says that you cannot go on giving HRT for a longer time. I think the studies related to HRT are quite time dependent because we cannot put somebody on HRT and really look at the results 6 months after HRT. We have to wait for years together, like 5 years, 10 years, 20 years in fact, like we can see from the data from UK data. And of course, we, as you said, abrupt stoppage in younger women, there is a lot of literature that says has led to cardiovascular events and strokes because of some different phenomenal atheromatous plaque formation that happens in younger women as compared to older women. So that has been proposed that you should go slow and don't stop abruptly.
I think we thank any question from the audience. Yeah, there's somebody. Sure. Mike.
प्याज काट दो बेटा. When she started chopping the onions, she had watering in her eyes. So rather than finding how it will not lead to watering of eyes, the mother counseled her daughter कि बेटा ऐसा होता है. क्षयति इति शरीरम. Excellent talk and excellent, I am not a gynecologist, I am a surgeon. I am just sharing my thought process. So whenever we meddle with physiology, we doctors, we are here to alleviate the suffering, but there is something like inevitable. So we treat pathologies. We should not meddle with physiologies. This is physiological. And a woman needs to be counseled कि ये तो होना है, dryness आनी है, ये hot flushes होने हैं, and they are not permanent. With time they get adaptation. But anyway, because we are most of the time market driven, the earlier lecture was also very good, hypothyroid. But who decides these cutoff values?
So I'd like to take that point.
Thank you, thank you.
Actually, this is the first step we do. Counseling, definitely we do. And we do not give to all women HRT, but there are indications.
No,
Because
no.
we are getting patients.
Not to offend
Yeah,
anyone.
it's a huge list where we're not supposed
There
to
is
just
a
a-
lifestyle
sir,
modification
sir,
which
just
is to
a
be
comment.
taken
Given,
first
yes.
hand.
Sir, just I would like to give a
And
physiological
counseling,
comment.
yes, it has to be done.
The comment is that post WHI trial, so this was seen that why this happened. When we are giving to a younger woman that's around 50, 55 years, it is not happening. But when we are giving to age 62, 63 years, it is happening. So it was extrapolated from WHI that when you keep on giving a hypoestrogenic woman the estrogen when her receptors were intact and they were just getting the physiological dosages of estrogen, they behave differently than a woman who was actually deprived of the estrogen. Her receptors never received estrogen for almost 10 years, and then suddenly you prime her receptors with the estrogen. You are giving same dosage of estrogen, but the scenario, the physiology that you were trying to convey or say has changed after 10 years. All these years she was getting estrogen, so she behaved differently. But when she did not receive estrogen for 10 years, but then suddenly you give her estrogen, she behaves differently. So that's a concept actually that why we should initiate early and
I think the session can be concluded by a take-home message that within 10 years of menopause, treatment should be considered. In women, we think that you should give. Actually, we understand.
There are so many women
Thank
who
you so
achieve
much.
menopause earlier because of premature menopause that we deal with IVF.
POF,
There are a huge cohort of patients nowadays, 1 in 20 women who experience menopause before 40 years. So it's not that we can let them cry. We have to do something about it. Yeah.
We
Yes.
can discuss over tea now. Thank you, Dr.
Excellent. Yeah.
Thank you, sir.
Thank you.
Thank you.